Yes, I am. That's good. So you should see my microscope screen now, which presently is blank. And so this is, again, bear with me. When I'm doing this, I have to flick through multiple screens for the clinical records and the camera display. So this is a patient born in 1951, so that makes them 73, coming up to 74. Actually, they are 74. And they presented with a white cell count of 7.3, hemoglobin 114, neutrophils 5, platelets 322. So not particularly high white cell count, actually, which is unusual. So this is the biopsy. So 74. So it's markedly, almost maximally hypercellular. The trabecula and there are about, it's adequate. It's a little bit hemorrhagic at this end, but you've probably got here, you can see the cursor say 1, 2, 3, 4, 5, 6, maybe 7 marrow spaces, between 5 and 7 marrow spaces. I think it's adequate for diagnostic purposes because the hypercellular marrow is well represented. This is, let's see where we're up to. Yeah, so we've got hypercellular marrow, almost maximally hypercellular, and the cells are a mixture of erythroid and myeloid. I think this is a slightly unusual case. So we've definitely got, let's just get the color balance correct for you. So I think we've got good erythropoiesis, these islands here, there, and there. We've got quite a lot of eosinophilia, got prominent megakaryocytes, including occasional micromegakaryocytes, but mostly the megakaryocytes are cytologically normal. They're not forming clusters. And then in the background, also got lots and lots of immature myelopoiesis. So left-shifted myelopoiesis, but it does show maturation. So we have got band forms, and we've also got occasional neutrophils, another neutrophil there. There's more neutrophils down here. So we've got a predominance of increased myelopoiesis with left shift, but all stages represented. Loss of paratrabecular fat spaces. So I think it's neoplastic on that basis. So here the paratrabecular fat spaces are lost. This is just retraction artifact, but you can see here no paratrabecular fat spaces left. The erythropoiesis is slightly disrupted. There's an erythroid cell on its own. There's a couple of their own there. And those are the features. I can't really see any blasts. I don't think that these cells are blasts. I think they're just a very immature myeloid cells. So the aspirate, excuse me, the aspirate was reported as normocellular, but with features suspicious of chronic myeloid leukemia. I just look at the clinical details for this case. Just bring it up. 3, 4, 5, 1, 3. So they have had cytogenetics. The cytogenetics is presently pending. They've had molecular genetics. It just says it's been processed for DNA. So we haven't got a molecular genetic result yet. The aspirate result said it's normocellular, and the features are diagnostic of chronic myeloid leukemia, but BCR-ABL is required. It's interesting that, so in terms of a diagnosis of CML in this, what would go with it is the marked myeloid hyperplasia with left shift, but all stages of maturation represented. What would and there's also increased megakaryopoiesis, which you frequently get. In chronic myeloid leukemia, often also get a bit of eosinophilia. It's unusual for the erythroid component to be so well preserved, to be honest. Usually it's wiped out a bit more than in this case. I'll show you the immunos to show you how much erythroid there is. So this is the myeloperoxidase. And you can see, it's obviously markedly expanded. Myelopoiesis. In terms of erythropoiesis, it's a rather blood-stained sample, so I won't show the glycophorin A, but showing the E-cadherin, this is quite a lot for CML. Usually CML, you just get isolated, scattered small erythroid islands, but here we've got relatively cohesive islands through the marrow. Relatively cohesive islands through the marrow, and also occasional single cells lying on their own. So I think that degree of erythropoiesis is unusual in chronic myeloid leukemia. So this one really rests on finding the BCR-ABL fusion transcript to make the diagnosis. CD61 was increased. The cells are generally of normal size. I think that these smaller things in the background are generally platelet fragments rather than micromegakaryocytes, occasional micromegakaryocytes, but certainly increased megakaryopoiesis with with virtually no clusters. So even though there's lots of them, the cells aren't lying right next door to each other. So slightly atypical, and really needs BCR-ABL to be confident of the diagnosis in this case. But no evidence of transformation and no excessive blasts. So are there any comments or questions about that case? A bit of a myeloproliferative theme going on today, just coincidentally. So don't often see many biopsies of chronic myeloid leukemia. The diagnosis is often just made using an aspirate and molecular testing. So it's type of condition we used to see a lot more, but now we don't see as many chronic myeloid leukemias, because they're usually and certainly obviously the monitoring of it is done by PCR, so we don't get many defined biopsies for it. So I've said the appearances are consistent with chronic myeloid leukemia, chronic phase, but it needs correlation with the other factors to be certain. That one. So the next one is one from one of my colleagues. Also a myeloproliferative disorder. Let me just bring it up. Yeah. So this is a 45-year-old woman who presented query systemic mastocytosis. Her full blood count, hemoglobin was 123, white cells 4.2, platelets 221, and neutrophils 2.2. So she had a very adequate sample. This is the sample. So this is an adequate trephined core. Bony trabeculae look okay, maybe a bit thin actually, particularly here, a bit thin. I'm not sure they commented on that. Yeah, mild remodeling changes. I think that the okay. And most of the biopsy has got normal hematopoiesis. The cells at all stages of maturation. So we've got good erythropoiesis, good myelopoiesis, megakaryopoiesis, not really represented much in that field. We're going through the biopsy, it looks the same most of the way down the trephine until you get to this area here, where we've obviously got some kind of aggregate here. So if we compare that to the retic is a really good way of trying to see aggregates of spindle cells or mast cells. So looking at the retic, generally it's not increased. But if we go to the far end, got focal area of increase here. So if you ever see a focal area of increase here, like this, you worry that there might be an infiltrate. Generally with mastocytosis, the increased reticulum will be around the trabeculae, but obviously not exclusively so. In this instance, it's in the intertrabecular zone. There, increased retic, I'd say that's grade 1 focally. And that corresponds with this area, if I can get to it, down here, yeah. So the thing is, when you're looking at a marrow for query mastocytosis, it can be very focal. So here we've got some eosinophils and then this kind of pale eosinophilic area with spindly and plump cells in it. And there's also not just these are probably mast cells, but we've also got eosinophils, maybe some basophils and plasma cells as well. So in order to make a diagnosis of systemic mastocytosis, you've either got to have lots of spindle cells or ideally aggregates of cells more than 15 cells. So I don't know, I'm so tired just now. Excuse my yawning. So this is the Giemsa. So Giemsa is a useful stain, always. If you haven't got access to immunohistochemistry, do a Giemsa. And here we've got nice aggregate of mast cells there, and also the same in this area here. Now on this, the cells do look a little bit dispersed from each other rather than all aggregated together. So mast cell tryptase will identify some of the mast cells, but not actually all of them. If you want to see all of them, you either got to do a mast cell tryptase or a CD117. So if I show you the CD117, this shows how many of them there are in those areas. And CD117 is probably the most useful of the markers. Obviously, there's a lot of background. Well, some of these will be normal mast cells, and a lot of these are spindly cells. So a normal mast cell should be kind of smallish and round to ovoid. Here we've got lots and lots of spindle-shaped cells. Here, here. So I think all of these cells in the background, all of these cells here are abnormal neoplastic mast cells, because they should look more like that rather than this spindly morphology. And you've got that spindly morphology all the way through the marrow. And then we also have in the areas where the Giemsa showed an increase in mast cells and the H&E showed an apparent increase in spindly cells, you've got these dense, large aggregates. And you're meant to have more than 15 cells in an aggregate. If you've got more than 15 cells in aggregates, then it's systemic mastocytosis. So often presents with another hematological malignancy. It hasn't done on this occasion, but you might get, and then you call it systemic mastocytosis with an associated hematological malignancy, which could be myeloid or lymphoid. So very, very strong staining for 117. The mast cell tryptase is a less strong stain. That's why if you're going to have a choice between them, given resources and so on, it's probably best to go for 117 rather than mast cell tryptase. So this is the mast cell tryptase. And you can see even this area here, it actually projects slightly better on the camera than it does down the scope. But obviously, it is highlighting them, but nowhere near as impressively as the 117. And if these are neoplastic plasma cells, mast cells, they'll be positive for CD2. This is CD2. And we've got strong CD2 staining coordinate with the mast cells. So this is a case of systemic mastocytosis with these large aggregates of more than 15 cells. But as you can see, the aggregates are quite patchy, actually. So if it had not been a very good biopsy, you could easily miss them, actually. But they're accompanied by a general increase in mast cells with a spindle cell morphology. And that's what gives the game away. So that's my colleague's case. So I have to keep it separate, give it back. And now I want to show you this case. So this is a case of mine from today. This is a 43-year-old woman, so similar age. And they've got platelets 337, neutrophils 3.1, hemoglobin 138. And again, they've got this person's got cutaneous mastocytosis, and they're questioning whether it's in the marrow as well. So start off with the H&E. This is a bit more subtle, this one, actually. And I'd welcome any opinions on this one. So let me get the water white. So I think the trabeculae are within normal limits. It's obviously a very adequate marrow. Cellularity doesn't look too bad. I think it's probably within normal limits for the age of the patient. There is a little bit of eosinophilia. Actually, you can see that even at this power. And you can definitely see it on the Giemsa. Otherwise, erythropoiesis, myelopoiesis, megakaryopoiesis, they all seem to be proceeding normally in this biopsy. You've got lots of myeloid cells, occasional erythroid cells like this here, occasional micromegakaryocytes, another small erythroid island there. So not much in the way of mastocytosis. But the whole thing does look a bit tickled up and slightly left shifted in the myeloid series. There are no aggregates to see morphologically. Show you the retic. That again, I think the retic is mildly increased. Probably grade, I think I called it grade 1. And very focally grade 2, but it's kind of diffusely increased through the marrow. There's not any single nodules of it. Maybe there, as in the last case. So looks okay. But look at the Giemsa. Let's find it. So the Giemsa is showing the eosinophilia. You see it quite nicely on this power. Lots and lots of eosinophils scattered around, and occasional mast cells with this purple granules. But there's no aggregates like in the previous one. But if we look at the immunos, I've got an immuno for 117 in particular. I think this is a bit more subtle, this case, and I'll have to discuss it with my colleagues. So, where is it? I'll just open the window, actually. It's gone really, really warm in this room for some reason. That's probably what's sending me to sleep. Okay. Right. Yeah. So here we have 117. Now, I think we've got an increase in mast cells here. And also, there's no aggregates. We'll just go to low power and go all the way down the biopsy. And there are no aggregates. But there is an increase in mast cells. And to my eye, a lot of these look either spindly or ovoid. So I've got spindle-shaped cells there. And they just look kind of big compared to normal, either big or spindle-shaped, elongated. And lots of them are spindle-shaped and elongated. So we haven't got aggregates developing. We have got an increase in abnormal mast cells. So I think this is systemic mastocytosis. Now we can also look at mast cell tryptase, which is weaker than the 117, just like in the previous biopsy. That's the control. Let me just find the test. There's the test. But again, this is also showing an increase in spindle-shaped mast cells. Yeah. So lots and lots of spindle-shaped mast cells here. And these are also aberrantly positive for CD2, which shouldn't be positive on normal mast cells, but is positive on these cells. And that's quite a good marker. So obviously CD2 is present on T cells as well. So you have to kind of like subtract them out. But we've got little aggregates there. I mean, these all look like, a lot of these look like the there we have them. So we've got elongated cells there. Oh, it's so dark. That's better. So elongated CD2 positive cells. So that's the second case of systemic mastocytosis. We've had a case of chronic myeloid leukemia and 2 cases of systemic mastocytosis. That's quite unusual to get that much myeloproliferative, and they're both relative. They're infrequently seen conditions. I've got 2 more of my cases, but they are not particularly informative, so I'll leave those 2. And I'll go on to some more cases that I've kept aside. That one. And that one. Yeah. Right. This next one is a really fascinating case. There's 2 pathologies going on in here. So this is 78-year-old man. Excuse me, just see where we're up to. Yep, 78-year-old man who's got hemoglobin of 184, white cells 16.1, platelets 466, neutrophils 13.4. So it was JAK2 positive, and with that hemoglobin, it was query polycythemia vera. It was a patient from Tameside, which is East Manchester, which has the unenviable distinction of having the worst health in the country, unfortunately. And you won't believe this probably, but it's got the average healthy life expectancy. So the average healthy life expectancy in Tameside is in their mid-50s. That doesn't mean to say that people die in their mid-50s, but they after their mid-50s, they are not healthy at all. It's got terrible rates of heart disease and lung disease and mental health problems. Anyway, so this patient lives in Tameside. If I can get the color balance right. And they've got high hemoglobin and they're JAK2 positive. So Mara's got a number of features in it. The first is this hypercellular area. Let's just get the color balance right. So this hypercellular area, you've got increased megakaryocytes with some focal clustering and lots of erythroid cells. So higher power, got markedly increased erythropoiesis. We've also got increased myelopoiesis. So this is a feature of polycythemia vera, in that not only is the erythroid increased, but the other 2 lineages are also usually increased, and you lose the paratrabecular fat spaces. That's lost down here, and you've got hypercellularity in the marrow. So here we've got markedly expanded erythropoiesis, but also myelopoiesis is increased, and megakaryopoiesis is also increased. I can show you the immunos for that to demonstrate how much erythropoiesis has been increased. If I show the E-cadherin, for example, so this is the E-cadherin. To be honest, you usually see more E-cadherin in polycythemia, but the patient has got JAK2 positivity. I'll look at the glycophorin A in a minute, because that's not a massively expanded early erythroid precursors. Now, bear in mind that E-cadherin is the early erythroid precursors, and the later ones are glycophorin A, which is somewhere here. It's got to be in here somewhere. Glycophorin A. Yep, there it is. So there you can see that's a lot more expanded. Yeah. So we've got marked expansion of myelopoiesis, sorry, of erythropoiesis in this field here, with these large expanded erythroid islands, and the asynchrony between the E-cadherin, which is early precursors, and the glycophorin A, which covers all erythroid cells, but including all the later forms, shows that this is not, the erythropoiesis is increased, but is not particularly left shifted. It's obviously towards the more mature end of the spectrum, which is why you've got a small amount of E-cadherin, but a large amount of glycophorin A. So that pretty much confirms the diagnosis, particularly with the JAK2, of polycythemia. But also in this case, we've got these areas. So kind of polytypic lymphoid areas. They're paratrabecular, which means they're almost certainly neoplastic. And we've got quite a lot of them. I think if we've got at least two here, paratrabecular lymphoid aggregates, that means they're definitely neoplastic. You may be allowed one, but not two. The cells here, we've got a mixture of some kind of elongated centrocyte-like cells, some larger blast-like cells, and then small lymphocytes. So to cut a long story short, we did some immunos on this to see what these cells are. They look lymphoid. Of course, other paratrabecular aggregates can include mast cells. But when you get paratrabecular mast cell infiltrates, they're usually more elongated cells. You don't get so much of a variety of cells. Even if you get more plump cells, which you can sometimes get some plumper mast cells as a paratrabecular aggregate, they'll all be the same, not this jumbled up mix that we've got here. So I think that there's only one thing. The most likely thing that this would be is follicular lymphoma. And follicular lymphoma is said to preferentially cause paratrabecular aggregates, but that doesn't mean to say that all paratrabecular aggregates are follicular lymphoma. So the immunos for that did a CD20. Let me just find it. Yep, there's CD20. So that highlights the marked paratrabecular aggregates, and also did a CD10. So CD10, not particularly positive, actually. So CD10 was negative in these areas. Okay. Just bring up the report. Let's see. Oh, actually, the report says that CD10 was positive, but it doesn't look positive to me. Well, it's negative to me. Let's just see. Yeah, okay, CD10 is positive. I was looking at the wrong bit of the biopsy. So CD10 is positive, strongly positive. And I think we've also got a BCL2. BCL2. So BCL2 is expressed a lot in myeloid cells and so on, and in basic marrow cells. But in this instance, we've also got strong BCL2 staining in those paratrabecular areas, and the combination of CD20, CD10, and BCL2 almost always equals follicular lymphoma. So this is an interesting case with both polycythemia vera and follicular lymphoma together. So very unusual. So that's that one. Work out where I'm putting them all. Yeah, I'll go for this. I think we'll do this one next. So this is another lymphoid case. It's a patient born in 1953, so 70, coming up to 72, presently 71. Hemoglobin was 110, platelets 77, neutrophils 1. Let me just bring up his details. So he's got mild anemia, low platelets 77, and neutrophils low at 1. And he's 71. So for his age, he's got yeah, it's hypercellular. So he's got a hypercellular marrow. It's a bit of a thick section, that. Let me just get a better section. Yeah, that's better. So it's certainly an adequate trevine biopsy. Nicely, lots of material there. Trabeculae, I think, are focally thinned, particularly in this area here, which goes along with his age, 71. And this is his marrow. So hypercellular. Looks a bit jumbled up. Erythroid islands not easy to see. There's some eosinophilia going on here, for instance. And erythroid islands are jumbled up, and there's obviously left-shifted myelopoiesis, a lot of left-shifted myeloid cells, but they are maturing nicely to neutrophils. Megakaryocytes, well, we've got one there dead center, some more there. I think that this is suspicious of a micromegakaryocyte, and maybe that's an erythroid cell, I think. So there might be some micromegakaryocytes. As I've said before, finding there's another micromegakaryocyte possibly. Finding them on the immunos is better. Another small megakaryocyte there. These are two small forms as well. Quite a lot of eosinophilia. So we got mild cytopenias, particularly in the platelets and neutrophils. A jumbled up hyperplastic marrow. And if I show the CD61, megakaryocytes, you can see the megakaryocytes are definitely increased. And we have got lots of small ones there, 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 there. These are all small micromegakaryocytes, there, there. So the appearances in terms of the hyperplasia, the jumbled up nature of the lineages, the micromegakaryocytes in particular, is suspicious of myelodysplasia. And then in addition, there were these lymphoid aggregates. Go back to the H&E. Scattered through it, like there. And these were all intertrabecular in this case. I think they're all intertrabecular. Yeah. Small, slightly irregular lymphoid cells. So we did some immunos on these. They were positive for CD20. And this just shows the extent of them, which you might have got from the H&E. Importantly, there are no blasts. There's no transformation. They were negative for, let's see, CD5. I think we've got CD5. So we've got CD20 positive. CD3 just shows some infiltrating reactive cells. CD5. So the cells are also positive for CD5. So it could be either CLL or mantle cell lymphoma, but they were negative for both CD23 and cyclin D1. So the question was whether this was a CD5 negative lymphoproliferative disorder, which would include marginal zone, but it didn't really look like that, or whether it was a CLL which was negative for CD23, or a mantle cell which was negative for cyclin D1. So we did 2 additional stains. We did LEF1 and SOX11. So LEF1 is specific for chronic myeloid leukemia. I'll show you the test and then the sample. So this is the test for LEF1. And then this was so that was the control for LEF1, and this is a test. So it's a nuclear stain, and it is a little bit subtle, but you can see that the cells show nuclear positivity for LEF1. That was nice, positivity. And we don't often see this, to be honest. On the other hand, we don't often do it because usually we get the answer from the other immunos. And then we also did SOX11. So the control had worked, and SOX11 was negative in those cells. So SOX11 will be positive in mantle cell lymphoma. So the final diagnosis was probable myelodysplasia, but required correlation with aspirate and clinical features, with additional chronic lymphocytic leukemia. Turns out he had a known diagnosis of chronic lymphocytic leukemia, so we probably didn't need to do all those extra immunos. But I don't think he'd had a diagnosis of that for some years, so we just needed to check it. So that's that one. What else? We've got a couple of plasma cell lesions. You've seen lots and lots of plasma cells, I know. I think I'll show you one more case. So this one, uh, someone born in 1935, pretty old, and they've got hemoglobin of 111, platelets of 84, neutrophils of 36.4, of which monocyte count of 25.2. So monocytes are a high percentage of the white cells. And they've got left-shifted neutrophils. So there's query AML or not. Bit of a fragmented biopsy, which is always difficult to interpret because there's lots of bits to it. But for someone aged 89, you kind of think, oh my God, I wouldn't want to be getting a marrow when I'm 89. Very, very cellular. So it's obviously either a myelodysplastic or a myeloproliferative. And I think that given the neutrophil count of 36.4, you can't just say it's myelodysplastic. So I think this is a myelodysplastic myeloproliferative neoplasm because there's obviously a proliferative component in the peripheral blood. There is low platelets and slightly low hemoglobin, and it's very hypercellular. That means it's almost certainly dysplastic. So when we look at it, most of it, almost all of it, is myeloid. And it's very left shifted with lots of these ellipse, large cells. I think there are some blasts in here as well. So markedly left shifted, but maturing myelopoiesis, lots of eosinophils, hardly any erythropoiesis visible. We've got an erythroid cell there, for instance. Not much in the way of megakaryopoiesis on this either, but there could be lots of megakaryopoiesis in terms of micromegakaryocytes. So we'll look at the immunos for that. So if we look at the ecadherin, for instance, for the erythroid, so there's hardly any erythroid. It's very, very scanty. And the cells are almost all lying on their own, hardly any islands. So that is dysplastic. Myeloperoxidase, by far and away the most, the dominant series. Okay. So dominant, so let me just find it again. It's not very helpful, is it? Sorry about this. So very dominant myelopoiesis. And you've got a mixture with these more granulated forms, which are the maturer ones, and these darker ones, which are more like immature precursors. CD61, megakaryocytes. So not as high as you might expect, but you see a very high proportion of them are small, which is why we couldn't see them easily in the H&E. Small little micromegakaryocytes. That's another dysplastic feature. And we've also got quite a lot of blasts. So this is CD34. You have to look carefully for 34. Yeah, so in this instance here, we've got lots of positive blasts. So there's an increased number of blasts. And also we did CD68, which highlights the monocytes because it's a macrophage monocyte marker. What is it? No, CD56. I don't want 56, I want 68. 68, yeah. And you can see a large number of positive monocytes here. So this was considered to be myelodysplastic myeloproliferative neoplasm, consistent with chronic myelomonocytic leukemia, given the high monocytes in the peripheral blood and the dysplastic features and the high neutrophil count. So I'm probably going to stop there because I've got another meeting at 3, which I need to give myself just a quick breather for. And also to give you all time to ask any questions. Are there any questions?